My name is Anne-Marie Wall. I'm a dietitian and professor at the University of Oslo and Hospital Oslo, and I'm chairing the session together with.
Yeah, my name is Willis. I'm a state of Artigas University, and I think we can actually start with the first session, which will be done by Marta Csanalosi Artigas from Yes, exactly. And the title of your presentation is Smart Solutions and that.
Yeah. Thanks. Well, they already said my title. Just to point out that this is a presentation that I did together with Elena Lalama. So very happy to be here. A bit the agenda of today. I'm going to talk first about apps or digital health, then our own experience with the protein project, our current project ADAPT, and then some open questions and take-home message. So, mobile applications. This here I show you an image of the first app that was developed in 1997, which was Snake. We've come a long way since then. And here also, on the other side, you see the first diabetes app that was approved by the FDA in 2013. So, mHealth is just an abbreviation for mobile health, which means that you use the phone to promote public health or medicine. And right now till 2022, we see that there's more than 54 mobile health apps that are available. And from those, the ones that are more downloaded are the ones related with nutrition, healthy lifestyle, and so on. So there's a huge demand for these apps. The advantages to use them is basically they promote a healthy lifestyle. In the case of, diet-related diseases, they help the prevention. They can assess the dietary consumption. Then they enhance also the communication with the healthcare provider and the user. And they also reduce costs and help the dissemination of public health information. So, anyone has heard the term DIGA? Maybe someone not from Germany. Ah, great. Yeah. Well, this was in Germany. They had this pioneering or first thing that DIGA is translated. It's a digital health app, which means that there were applications that they had to have this criteria. They had to be CE certified medical devices of risk class 1 or 2A. And that meant that these apps, they could be prescribed by a doctor. So you could go to your physician, he could prescribe them, and then you could use them. Here I show you the 6 that are right now available in Germany for type 2 diabetes. And just to point out, these 5 are new of this last year. So there's always way more being researched and being certified that we can use. This is what happens in Germany. We do our research in Germany, but other countries also have different things. In the case of Belgium, for example, they have this mHealth Belgium, which is a platform where they also have all these validated apps that also they can be prescribed and they're covered by the health system. In the case of England, they have this NHS app library where there's also in end of 2022, they had 97 apps available, but they're not covered by the state. In the case of France, it's the other way. They're covered, but they don't have these libraries. So in the European Commission, they had a roundtable to discuss what are the challenges of bringing these apps into the market. And they found out that 2 biggest ones are to provide the skills among healthcare providers. So this means to give them skills so that they understand how they work and they recommend them also to the patients. And the other one is to collect clinical and economical data for reimbursement. On the other side, we have other obstacles for the app development, which is the same as we have to have knowledge from the side of the healthcare provider, also from the user. He needs to actually be able to use technology to know how an app works, how a phone works. Then we also have a lack of stakeholders' involvement. This means that if you don't involve or you don't fully understand the needs of the person who's going to use the app or being involved with the app, And that's also not going to help with engagement of the app, which is a huge problem in this app, which is that they start to use them, but they stop them. And it doesn't like, so you really need to understand this and to keep them also engaged. They've been doing a lot of research, and here are some things that could help. For example, the personalization, to add educational content, gamification, social features, app updates and support, to integrate wearables. For example, in the case of type 2 diabetes, you could add the information of glucose monitoring in your application. Then they need clinical validation. This means that you have to prove that your app works, that it actually has a health impact. And there's, well, with new technologies come also new ethical problems. There's all these data online, so it's vulnerable, and we don't have guidelines that regulate this. There's actually a consensus report from the ADA and the EASD that actually tackle or say that this is a huge thing, that we should really be doing something with these guidelines. So now I would like to know from you, from the audience, who has ever recommended an mHealth app? So hands up for yes. Okay, well, yeah, portfolio diet. True. And for no? Oh, okay, well, that does not represent. Here there was an international survey. You didn't reach this 45%, but there was a lot of abstention also. And so you have 45% of healthcare providers did actually recommend already an app. And from those who didn't, sadly, 22 didn't even know that they existed. But still, from those who did not recommend, 76 were like, they were willing in the future to recommend one. So here is maybe one of the most important slides, because this is what is important to having an app. And the most important, if you want to keep with one thing of this presentation, is apps need to be easy to use. If not, they're not going to use it. So do an interface that is completely like, that they can use it, that the user understands. If not, that's going to be his problem. Second one, free of charge and validated. This, if we include them in the healthcare system, as they already have a validation system and they're covered, you have them solved. And the other ones are these automatic food recording and automatic nutrient supported. I saw already some presentations where you showed, yeah, with a camera, we can maybe like guess how much percentage of fat or like the nutrient content. I'm going to go a bit deeper into that. There's two ways of introducing food into a system. You can do it manually. You say like, okay, like I ate an apple. How much of that apple did you eat? So many grams. Or you can do an automatic or semi-automatic method, which means that through a photo, a bar, like you can scan a barcode or maybe a little video, you can do this analysis through AI. And then you have like, okay, you ate so much and so much of this. Some of them also require a little input of the user. Here is an example of how in Switzerland, they developed an app where with just one image, what it did is first you did the food segmentation. So you took all the background out and identified this is the food. Then this app had the food recognition. So through granulosity, they could recognize what it was, if it was a steak, it was a potato, something like that. And then they also did a photo with this card so that they could also assess, like they could convert this into a 3D image and know the volume of how much they were eating. So you had an estimation of these are your nutrients, and that worked okay. But there was one thing, for example, fat was totally misestimated because photos cannot recognize this. There was a participant that was eating per meal almost 50 grams of fat. This represents already 400 kilocalories. So that's quite an amount. So challenges in these images, but cannot be identified. This, can you see the difference? No. Yeah. Also another problem. And a sandwich, how do you recognize what's inside of that? They cannot. So this image recognition, it's still something that we could use. I mean, it gives already a lot of information for the participant itself to understand, oh, I kind of ate like this, or and also for the one on the other side, the physician or the dietitian, if you have to do a consulting, you already have a lot of information from that. But still, we need something that is a bit more precise. And there's a lot of research going on in that topic. We have this hyperspectral food recognition, where you can see like it works totally different. It's a big machine that basically they did manage, that's a Danish group where there's someone in Denmark here, and they said, or they explained that you like to eat a sandwich with chocolate sprinkles. And they tried to see if they could differentiate with this camera the fact of having the sprinkles inside or a slice of cheese, and they did it. And the problem is like this machine, you saw it, it's this big, it costs 60,000 euros, so you cannot tell a patient like, please take it with you and analyze your food with this. So the food records are quite imprecise also. They've seen that even if you write the diaries and you analyze it with someone, then after, there's still like 60% of accuracy. And the more BMI, the less accuracy, the less that you report there. So that's why they're developing a new techniques to understand how are the eating behaviors of our participants. So they do, for example, machine vision, where they analyze the chewing, the bites, and how much the portion you eat and how often do you eat. Or there's also research being done by using snack box, where they actually can weight how much you ate, and then they estimate. Or also with your phone, you can also weigh the food. Or there's also chips. Chips can be implanted everywhere, like in the teeth and well. And here they understand, for example, when are the eating times through analyzing lactate or glucose. So maybe not all of these techniques are so developed right now, but maybe together or trying to combine these technologies will help us to understand better the eating behaviors of our participants or patients. So now I told you a bit of theory, and I'm going to tell you now about our own experience, where our group was in a European project where we developed an app called Protein, which is an acronym for Personalized Nutrition for Healthy Living. And what we did is we had this is our app, how it looked like. And we collected information from the patient. We did collect the CGM data, food preferences, health condition, physical characteristic, and also the dietary intake. And what we did is with machine learning and artificial intelligence, we created personalized meal and sports plan. And our aim, or first aim, was to improve time in range by 5%. To do so, we had a waitlist randomized control trial where we had 26 participants that we divided into two groups. The first one received the app and wearables. By wearables, I mean fitness tracker and the sugar sensors during 12 weeks, followed by 6 weeks only using wearables. And the other group did the other way around, first using wearables, and then they included also the app. Here are the characteristics of our participants from before and after this intervention. And as results, first one was time in range. Here we saw that actually time in range reduced by 5.5% whilst they were using the app. So when they were using the app, for those who don't work so much with time in range, the better, the higher, the better. So it was a success in this case. And then as I showed, we had these two groups. So here I also divided it. And we didn't see, like, we see that, yeah, while using the app, it's a bit higher, the time in range compared to the non-using the app, but it's still non-significant. This is also a very valuable thing that you do when you develop apps, which is to ask the user, what did you think of the app? How was it? And what we saw is that they reported that the app was not so easy to use. So there we have a thing that we needed to improve in our app. Still, they thought it was easy to learn how to use it. And also, like, they were kind of satisfied also with the app. And yeah, it helped them to manage the health efficiently. So we saw that actually our app, it did some changes in the lifestyle. And this also made that they could also have a better diabetes control. And this is our current project. It's not app development. It's rather a software, new way of non-invasive glucose measuring through a smartwatch where it's going to use photoplethysmography, and we're currently doing that. So after talking about all these topics, there's still some limitations or some open questions that I cannot solve. And first of all, if all these apps are so really personalized, like in the case of diabetes, we still don't fully understand if it's really a personalization or is it just that they recommend like rather low carb diet. For this, we really need long-term real randomized control trials. Another limitation is that almost all these apps are done by they have a Western diet represented in the databases. So whenever you go to other places, you cannot even find what you eat. And also it comes with language barriers because normally they're all in English. So if you are living in a non-English speaking country, that can be a barrier. And also limitation patient age group. You have, for example, babies, children, or elderly that's complicated, or also the health conditions are also limitation. Then we have this precision of food recognition. We still haven't have a golden standard. There's a lot of research going on, but still we cannot say, okay, this is the new golden standard that's going to help like to save some time to the patient. And then engagement. In our app, we did try. I mean, we had personalization, we had some wearables, we had a lot of gamification. There was also content so that they can learn. Still, attrition rates, like dropout rate was of 50%. So it's quite complicated to keep the participants engaged. And then we have these still ethical problems that I said with data protection. If you add also too much gamification, participants or users can become also addictive to these apps. And last thing is also like patients with eating disorders. Whenever they use these apps, it's like fuel to fire. They can control even more because then they can see everything, the calories. So yeah. And here, like last thing that I'm going to show, it's a take-home message, which is a recipe to for a good mobile health app for type 2 diabetes, where here you have the ingredients. The first one is to have a user-friendly interface. As I said, apps need to be easy to use. So start with that. Then if you include them in a healthcare system, they're also going to be validated, and they also they're going to be covered by it, and so you don't have to pay for that. Second ingredient is data security and privacy. So you have to mix in a bit of robust security and privacy measures by developing, for example, a guideline. And next ingredient is food content analysis. With what we have now, we could add a bit of technology. For example, in these apps, a semi-automatic method would be, for example, ideal, where you can actually use your phone to scan a barcode or take a photo so that it already recognizes some things, and maybe to be able to correct it so that you can write it by yourself, or maybe even adding more technology and being able to dictate it with a microphone. And then the next thing is to add also a bit of healthcare provider empowerment. If we steer a bit this empowerment of the healthcare provider, he's also going to recommend it to the participants. And this is going to help them to manage their diabetes. And this is going to save them some time and costs also. And the last one is engagement features. So you really need to season all these applications with engagement features, personalization, educational content, gamification, all of this, so that you can have at the end, like, bake the perfection and serve with confidence to improve type 2 diabetes management. So thanks again to my colleague Elena, and thank you all for listening. Thank you.
Thank you. Well, that was wonderful presentations. In short time, and it's about the year.